Good afternoon, everyone. Kathy, can you hear me?
Yes, I can. I can hear you fine.
Okay, great. Seth, did you unmute yourself so I know who you are in the organizer?
I am unmuted. Can you hear me?
I can. Everyone other than Seth, who's listed on there as an organizer, and if you will mute yourselves, just so I'll know which person Seth is to pass the screen over to him. Good afternoon, everyone. Welcome to the second webinar in our COVID-19 webinar series. Tonight, we're really happy to have Dr. Seth Keller with us. As many of you know, he is the co-chair of the NTG, along with Dr. Matt Janicki, who was on our first webinar. And I'll let Kathy introduce him a little more thoroughly than that. I just want to go over a couple of housekeeping things. As you'll all recall, if you wish to ask a question, on the right-hand side of your screen, there's a box that says chat. If you just click on that little plus sign that's to the left of the word chat, you can type your question in there and hit send. And Kathy Bishop and I both will be monitoring those questions as we go on. If you are having problems with the audio, make sure, first of all, that your computer speakers are turned up, that you don't have them muted, and that you are also on either the computer audio or the phone call, not that you are on no audio. I do see one person who shows as no audio, and so if anyone's having a problem with that, that may be why. And if that's the case, you may not be able to hear me say this, but usually people will send a chat message if that's the case. Also, on the right-hand side of your screen, you'll see a little line that says materials, and if you click on the plus sign to the left of that word, you will see a copy of tonight's PowerPoints that have been uploaded for your use. They'll also be sent out with the follow-up email that you will get on, let's see, today's Tuesday, you will get it on Thursday. So with that, Kathy, I am going to send the screen over to Seth, and hang on just a minute here so I know which one he is. Well, I'm not going to know that one easily, am I? Let's see. Hang on just a minute. I've got to find which one you are here, Seth.
Yeah, I was actually going to pull it away from you, Catherine, but I'm not sure.
Okay, yeah, good. No, go ahead. You can do that. Yeah, go up and hit change presenter. And
right.
Yeah.
Let me see. Let me think how to do that too.
Up there on the right-hand side, up the very top, it says change presenter. Bear with us, folks. We always have a moment or two that we have to get our act together. We have several NTG people who signed in as organizers, and it makes it hard to know who to pass the screen to. I think you did it, Seth. It looks like maybe it's coming over to you.
Okay, all right.
No, it's coming to me. It says show my screen.
No, we want to go to Seth.
Okay, I picked. All right, we're getting there, folks. We're getting there. Let's see. Let me try that again. Let's see here.
Oh, now it's been asked to make me the presenter.
Okay. Because Catherine, you have my most updated slides, right?
No, these are the ones you sent yesterday.
Okay, we're getting it. We're getting
You sure, Seth, you didn't have the screen to begin with?
No, that was me.
Okay.
All right, here we go. Let's see. Here we go.
You got it?
I think so.
Yep, it looks it.
Okay.
All right. Okay, with that, Kathy, I'm going to let you, yep, I think we did it. So, Kathy, I'm going to mute myself and let you take over and do the intro.
Will do, thank you. I'm Kathy Bishop, or known as K1, with the three Kathys that are part of the Education and Training Committee. I am the co-chair of the National Task Group ID and Dementia Practices Education and Training Committee, one of the lead and master traders. Most of you, about 3/4 of you who are on know us and are here because you are affiliated regional trainers. Additionally, we do have approximately 40 others who are general, what we call general public and community. This is the very first time that we have opened up the webinar offerings for our NTG affiliated trainers to the general public, and we did this because we felt there was such a need for this information in the midst of the COVID-19 crisis. We are trying to provide practical and useful and hopeful information to you to help you all, that we so respect that you've taken this time to be on with us, and the work that you're doing in the field. It is also my pleasure for the second in the series, and those of you who this is the first, you just registered this past week, you will have access to last 2 weeks ago recordings, and all 4 in these series will also be available by the end for any that you may have missed or you want to listen to again. You have to have been registered, and if you didn't register in your own email, you may not receive the information, so you need to check with however you were registered, and whoever registered you, they will be receiving the information. As I said, it is my pleasure to introduce Dr. Seth Keller. Seth, I was trying to think last night, was it 2009 that we first talked, I think?
I think that could be true. That's right.
At that time, I was at the University of Rochester School of Medicine and Dentistry, and Seth had found me on a website because as a neurologist in New Jersey with a very active practice of working with people with intellectual and developmental disabilities, and also working with a number of the organizations who serve, including Bancroft, one of the organizations in New Jersey that he provides medical assistance, called and said that there's a real need to understand dementia and types of dementia in people with IDD. I'm not sure where to go. I'm not finding any of the research or any of the information. And that was the call that I didn't realize would become, I hope, a lifetime friendship. As Seth continued to call others. And our first meeting was actually in St. Paul, Minnesota, correct, Seth?
That is true.
Very first in person when we all met each other. And here we are in our 10th anniversary this year, actually celebrating. We hope to be celebrating, obviously not celebrating in the midst of what's happening. We're trying very hard to build up our resources and be able to help you during this very, very difficult time. I had hoped to be able to announce tonight where those that did pay, 90% of what you paid will be going to a COVID-19 relief fund. As of late this afternoon, they still did not have the link up, and I'm waiting for the link. So the next time we're together, which is next week, I will be able to announce where the funds are going to. And also, if any of you on this call tonight know of any funds, if you would also forward them to myself or Catherine, so that we can also be listing links, because we really would like to promote those funds that are available as relief funds. I think your presentation will talk for itself, and so Seth, I don't want to waste any more of your time, and again, it's my honor to turn it over to Dr. Seth Keller.
Thank you, Kathy and Catherine. Do you hear me okay? Is my volume fairly good?
Yes, it is. You're fine.
Yeah, well, thank you for the information. And we're living in crazy times, aren't we, everybody? I saw people signing in, and a lot of you I know, and it's wonderful to be amongst friends, honestly. But we are living in crazy times. All of us in one way, shape, or form are affected by COVID-19. And I'm a neurologist that's been training and practicing for a long time, and I do focus on aging populations. So the issues of dementia have been near and dear to my heart. And in my presentation or preparation for this, which I do a lot of due diligence to put this all together, and Kathy and Catherine, you don't know this, but my mother was just diagnosed with COVID-19 several days ago, and it's surreal. So I'm living not only in my own practice of people who I'm caring for in my practice that are IDD, dementia, but in my own life, my mother has advanced Parkinson's dementia. I don't know if she'd be happy for me talking about her, but she's 9 years old, and sadly enough, she's been living in a nursing home outside of Philadelphia. I'm in southern New Jersey. So the weird part of what I'm going to be talking about, and this is not like I was going to think about talking about my mom, but is really so crazy because so much what I'm going to be talking about is so comparative to what me and my family's living through now personally, and it's a weird, surreal situation to kind of trying to remove myself professionally and otherwise. So I had debated whether I was going to say it, but for those that know me, I'm pretty transparent, so I really wanted to speak on that. So surprise, my mom's got it, and she's not doing that great like many people. I'm going to come back to these issues that are going to be very clear to this issue. So this is a real deal issue, and it's great that the NTG has been able to be fluid and flexible to be able to come to this discussion about COVID-19, because if we're in crisis mode and those with IDD and dementia are not leaving, they're staying there, and we need to get to the focus on them. So I'm glad we're doing that. Just as a disclosure, I have nothing to disclose except my own heartfelt want to talk to everyone here and care about this topical area. And I've been showing these interesting pictures because in many respects, we hear about COVID-19 and people think of it as like the silent enemy of some sort, but here are these amazing, pretty pictures, but they're deadly creatures at best. But I was able to say, oh my God, these are really pretty images. How could they be so harmful? So I'm going to be showing different images, and this is scary stuff, but I have nothing to disclose. And in generality, what I'm going to be talking about in the next 50 hours of your life, I'm being facetious, I decided to, because I have some time on my hands and I appreciate you putting up with me over the next hour or so, I decided to go into the weeds slightly into viruses, and I will absolutely be speaking on issues related to COVID-19, IDD, Alzheimer's, and all the things that you want to hear and learn about. But I really thought I would just do a little step back into virology 101. So bear with me. I'm going to go through a few slides that just talk about viruses into themselves. I want to just do that. Well, as a physician, that I certainly understand about infectious diseases. I understand about bacteria, and I understand about funguses, and I understand about viruses, but I'm not really sure, how anyone really always appreciates viruses, because they are there, and we've all had them. Anyone on the call, like it or not, has been infected by a virus one way or the other. A common cold, for instance, is a virus. A stomach bug is often a virus in many respects, but we really don't think of them, and they're all these silent enemies that we all have that pass our way. And on the screen, there are just certain pictures, and they all look kind of cool. They're kind of neat when you look at them, and they're magnified in this amazing way that we can never see them. They're these minuscule microscopic material that only under these amazing technology that can actually show them even what you're looking at now, which are somewhat diagrams of what a virus really looks like. But this is what these things do really look like. They do have that. And what a virus is, and just kind of give you a sense how that might differentiate itself from, say, a fungus or a bacteria. They are genetic material, and they are the types of creatures, I wouldn't really say creatures, that actually are like parasites. They actually go into living cells, and they use the living cells in our own body to basically take over them and work with them or destroy them. And that's how they do. So viruses into themselves are never really independent entities. They have to live and breathe and do all their mechanisms by living off of other other creatures' cells, whether that's animals or humans. That's what they do. And the differences really between viruses, aside from the pretty pictures and different shapes and all sizes, is how their makeup is. And I'm not going to get into too much weeds, or you'll all scream at me and walk away. But they are made up of different material, including DNA and RNA, and the sizes of them are very different. And what I'm going to show in the next few slides is how the differences are in terms of how they infect and how quickly they get into the body and how much they really can make people really sick. And they truly are an invisible enemy, because we as humans, we only feel the end result of what they do to us, which again is the cold symptoms, and certainly in COVID-19, all the things I'm going to be talking about. So I'm going to be showing some pictures and talk about the viruses in some respect before I get into more details. Well, not every virus has the same impact of all different viruses. And I want to kind of walk through these two different diagrams. The one to the far left, it says, how contagious is COVID-19 compared to other diseases, which are really other viruses. And the measles, you all heard of measles, and most of you probably, I'm sure, have received your measles vaccination. Not a lot of people nowadays, unless you don't get vaccinated, have had measles. The measles virus, and these are all viruses on this one diagram, is extremely contagious. So you can be near it from a distance or whatever, and boom, it's really quickly onto you as one of the most contagious viruses around, the measles virus. And then other viruses that are just listed here: polio, smallpox, mumps, AIDS, which is HIV, SARS, and then there's COVID-19. And below that is the influenza virus that we all hear about every year, and most of us may get our vaccinations or shots for them. And we all heard, I'm sure, much about Ebola. And I think it's always important to kind of talk about Ebola, at least in some respects, because we always hear about it in Africa, and it's there, and it's really terrible. But it's really there, but it's really not that contagious. It takes a lot of the virus itself, particles, to be able to get around the body for it to actually get in and cause the actual infection. The problem is with certain viruses is that if you get it, how bad truly will it affect you. So on the next little graph over to the right, it says, how deadly is that disease? Again, these are the different viruses. So for instance, if God forbid you get Ebola virus, 50% of people actually die from it. So it may not be overly contagious, but God forbid you get it, you're in big fat trouble. So that's really bad. And as you can see, as I walk down from Ebola, and I'm going to talk about MERS and SARS in a little bit, these other viruses are bad, but they're not really as contagious, or they're not as deadly. The problem, as I'm going to show to you, is what has happened with COVID-19 in terms of how much it's out there, as you're hearing reports every day in our country. So I'm going to get into that a little bit. And the coronavirus, I just want to give you a sense of the coronavirus, which is really the whole emphasis of our talks here and what you're hearing about in the news. And with the coronavirus, the word corona means like a cap or a head. So in these images, these really pretty pictures that are far to the right, these little pretty pictures, they show those little dots around the circular thing. That's actually the part that makes this virus look differently, and that's why they call it corona, because of these particulate areas that are around it, and that's why they call it corona. The coronaviruses have been in existence in humanity probably forever, and we probably never think too much of them, because most coronaviruses throughout our history could be very common cold viruses that who cares? If you get a cold virus, you get the sniffles and some congestion for whatever days you've all had it. So it's very possible that a lot of us have had other kinds of coronaviruses. The name and recognition of coronaviruses in our news and our press really started around the early 2000s, which was called SARS. And that's a severe acute respiratory syndrome, or SARS, which came out of a province in China. And there's another one that came out somewhat years after that called MERS, or the Middle East Respiratory Syndrome, and then one that we're dealing with now, God forbid, in our population, which is called the novel 2019, or the COVID-19 coronavirus. And the differentiation between each of these three more recent coronaviruses within our midst basically has to do with where did it originate from, how did it actually get into people, because it's thought that in these particular coronaviruses, they originate somehow in different animals, and somehow the animals that had the viruses then ended up getting into humans, and the rest is history about what then happened from human to human. And that's what it's thought between these particular three coronaviruses, that they were got in from animals to humans. And what you probably heard a lot about in China is it from these markets in China where they have these exotic animals that the Chinese people might use for foods or other kind of things, and somehow that entered into our population. So there are some thoughts as to what the differences are. And there are some statistics that show the comparison between these three more recent coronaviruses related to how much it was commonly infecting people. So SARS was about 8,000 people. The MERS was 2,400 people. And as of today, I had to, sadly enough, tragically, I had to update the COVID-19, over 25 million people, 2,500,000 cases in the world. And as of today, it's probably more than that later, is 174,000 plus people have died. So it's the problem with this particular COVID-19 virus is it's highly infectious. People can get it, and though it may not be as deadly as compared to the MERS, which had less people getting it, but more people died from the MERS than what's happening now. But it's not as contagious, if that makes sense, based on my prior slide. And the reason why it's called the novel coronavirus is because basically it's new, it's different, no one's really seen it before, and the 19 in the name is based on the year that it's there. It's not like there's been COVID 18, 17, 16 or whatever, but this is really why it's called COVID-19, and how long we're going to face its challenges in our population. We all watch the news, and it's hard to know for sure. Its fatality rate is anywhere from 1 to 6 or so percent. That's still be determined on how much it's really deadly in our population. And one thing as I get into talking about Down syndrome and dementia is there's, as you hear, there's these conditions that people can get that make them at higher risk of getting infected or sicker from having the COVID-19 virus: heart disease, diabetes, lung disease, others. So the issue about having underlying health issues certainly is very relevant. And also on that list, which I have to really think about, is also your immune status and how much you're immunocompromised. And as you know, those that have been mostly affected by COVID-19 increases by age. So on the graph to the right, the bar graph shows that as people get older, those that are actually dying more from it are the elderly population in general. And that's a statistic that came out within the last few months. So there's a lot of data that's out there. But this is not a disease, as you all know, that's only affecting those that are 85. And this is another statistics on this particular graph that showed that there's actually a lot of people that are younger that are getting it. And here's a graph that came out from the CDC about a month ago that shows there's a lot of younger people that are actually getting it, 30% in those between age 20 and 44, but they're not actually having the severe negative physical consequences, obviously including death, as compared to those that are older. And that's kind of why we all talk about, even though you're younger, you can get it. And if you're younger, if you get it, you can pass it on. So I know that many of you appreciate that. So if you have children or other people, family members or others that you know that are younger, they have to really appreciate this is a real deal that's important. The issue about the symptomatology of COVID-19 is there's always important to compare, do I have COVID-19 or do they have COVID-19 as compared to a common allergy in the environment or the flu. And so the graph that's over to the far left, it says flu versus allergies versus COVID-19. There's a lot of similarity between them, cough and being tired itchiness, sneezing. These are things that are very common. The difference is really between the COVID-19 virus is really they often have high fever. They have things that are actually more productive, like a dry cough, chills. They have sputum production more often. Those things certainly are not relevant. Headache is very common in COVID-19. So there really clearly are differences, but there is a commonality. So as I speak in the next number of slides about the evaluation of someone that comes in with COVID-19, most people are worked up and tested for the influenza or flu virus. So that's definitely there. On the slide or information to the right, it does show the most common symptoms or things that happen with COVID-19. Fever is problematic in most people, like it was with my mother. She had a temperature of 102 early on into her difficulty, as well as dry cough. So these problems are very problematic as I go down through the number: fever, dry cough, fatigue, throat problems, headaches. And the more we learn and collect data, we're seeing things such as diarrhea or other GI illnesses that we see sometimes are a sign of early virus within the body of a number of people. One thing that we try to figure out is, yes.
Yeah. Kathy, I've got a few questions, and I thought it was a good time to ask them because they're relevant to what you're talking about.
Should I go back?
Well, you can, but that's fine. Great. If the chronic conditions are managed with medications, managed or controlled with medications, is the risk still high, or is there a possibility they would be lowered?
You're talking about treating the symptoms.
The chronic conditions.
Oh, I see what you mean.
Well, if the person has chronic conditions such as heart disease or cancer or diabetes, but they're controlled through medication and other means, is it still a high risk, or would that reduce possibly?
Well, I hope, this is going to be kind of a facetious answer to your question. I have a heart condition. I hope I'm under control. So I hope, goddamn, I hope it's improved. I know that's not quite what you're looking at from my own preconceived notion of it. But I really think the problem is that as we're hearing about those that are actually getting, who are even sick and dying from COVID-19, these are people basically that are under control and sometimes don't even have risk factors. So it's really not really clear. I would certainly, my take-home message that I would respond to that question is I would be damn sure, one, to not get it, which is obvious, and number two, to certainly make sure that any current condition such as high blood pressure or airway disease is ultimately managed. Because I would absolutely believe, and I'm sure this is the case, that in someone that's infected with COVID-19 and already they're having a shortness of breath or airway problems or heart disease symptomatically, I am almost sure that they're going to be affected more by it. I would certainly think that's the case, but can data really show that for sure? I don't know if that the data will play that out, but I imagine it will. And that's really going to be a situation that the data is still being collected to be able to answer some of these questions, so we know for sure. But we're taking all things and saying, care for yourself, best manage these things in a lot of ways. That's what I would best way to put it.
Great, thanks. Another question is, and this was a question actually from last week. There was some indication that fever, people with Down syndrome may not experience fever as others in the population. We answered it last week that there wasn't enough data to know that, but I don't know if you have information different than that.
About people with Down syndrome and having a fever or not exhibiting a fever?
Yeah, the incidence of fever as one of the symptoms for the disease. And the particular article or research had initially shown that it implied that people with Down syndrome were less likely to have fever. And the question was, why is that? The answer we gave last week is, we would question that particular conclusion as there's not enough data, but we hope you might have some more information.
I don't. All I can say, and I'm going to be talking about data in a little bit, because I think really for us to draw a lot of conclusions or assumptions about the infection in those with Down syndrome, whatever age they are, about whether or not they had produced a fever or not, or how risky they are to getting the COVID-19 virus and getting sick. I think there's some debate about that, but I'm going to show you in just a number of slides that really is a recent thing that came out, research that came out that really explains why people with Down syndrome, in fact, are probably more at risk of not only getting COVID-19, I suppose, but also having a bigger impact from it. So I'm going to get to that in a minute. It's like a teaser. So I'm going to get to that
Kathy?
in a little bit.
Yep.
Can I just add one thing? I think part of that question too related to the fact that people with Down syndrome and dementia, as is true with people with dementia in the general population, don't always present with their symptoms the same way we would expect someone who doesn't have dementia, i.e. they might not have a fever, those sorts of things. I think it was kind of a double-ended question there.
Well, the thing, can I just comment, is that the thing about fevers, again, I want to kind of move on. I got a lot of material, but one thing I want to say is that the issue about fever is that when people get older in general, they may not have the immune system to generate a fever. So sometimes what happens when we get older in general, the body doesn't have the immune system. The reason why we get a fever, any of us, is because the body's immunity is fighting off the infection. And the fever itself is thought partly related to our body's ability to fight infection. So if the body is getting older, it doesn't have the immune system revved up, that might actually be sometimes of a reason why fever may not be generated in people based on their underlying condition.
Interesting. And one quick question for you, and then you can move on.
Yeah.
And this is from the audience. Do you know of any data on people getting the flu and COVID-19 at the same time, or is it one or the other?
Well, I've not seen that at all. I mean, there's no reason why they're like friends with each other and they say, well, let me do here, Mr. Flu, Mr. COVID-19, you already screwed them up. I'll buy you a bone and not give you an infection. I hate to be facetious, but you can get anything. There's no reason why someone can't get, Ebola, smallpox, the flu, and COVID-19. I mean, I'm kind of being facetious, but there's no reason why not. I think what it is that some of these are seasonal. So some of the flu virus is sometimes seen at different times of the year. The COVID virus that we're now seeing, COVID-19 virus, is a different beast. It's actually, we don't even know its seasonality. Is it going to be viable within different temperatures as the season goes on? So this is such a difference between the COVID-19 and the flu virus. So it could be, and it's also exposure. As you know, the only reason anybody can get any of these viruses, you got to get it from something. It doesn't happen in thin air. So but there's no reason, again, why people can't get both. That would be pretty nasty, no doubt.
Yeah, thank you.
But I would say this though, Kathy, is that everyone, and I don't think it's changed, everyone that comes in with symptoms of COVID-19, the first test that's given to them is a flu test. So they're actually seeing whether they have the flu. So I've not seen any data that shows any respect. I do know someone in our hospital, I work in a hospital, that someone had a different virus and it wasn't the flu virus. So there are other viruses that can masquerade as the COVID-19, but no doubt people are always tested for the flu virus along the way. And I'd say everybody that's been diagnosed with COVID-19, I'd be surprised if none of them, or I'm sure all of them have been tested for the flu. So this is a really busy slide, and I was debating whether or not I would show you. This is like in the weeds, science. And this is really what happens to people that have, over time, the virus within their body. There's different stages. So if you kind of follow me at the top, it says stage 1, stage 2, and stage 3, and this is over time. So when the virus gets in the body, it starts creating the symptoms of a fever, dry cough, maybe diarrhea, headaches, and during the early phases affects the blood. And then as time goes on, the virus may wane, but the body's reaction starts getting in the lungs more and more. And then as into stage 2 and stage 3, this is where people can get really deathly sick. And they can get, this is where they end up on breathing machines, their lungs and heart shut down. And it's thought that the reason this happens is it's the body's immune response that's fighting the virus, and the immune response of our own body is what ultimately ends up hurting the lungs and the heart. And that's really where the complication. So this is really relevant to not just an academic exercise, but it actually is relevant to treatment. And so on the very bottom, that light yellow, if you can see that, it says potential therapies. Those potential therapies are now being, I'll say, thrown at people with COVID-19 to affect the different responses, not only kill the virus, but also affect our body's immune system, which are actually supposed to be there, obviously, to help us feel better, but they're actually there to that also hurt people. So there's a whole information that's going on now about various treatments that treat people based on the virus and the body's immune response. So I thought that'd be an interesting thing. Again, I don't mean to be in the weeds with it, but that's important. So why is COVID-19 and dementia, what's the issue? Well, part of it is age. So in general terms, dementia is very relevant to most people over age 65. Of course, in our population with Down syndrome who have early onset Alzheimer's, that's different. So we certainly have people, certainly those that have Down syndrome that are in their 40s or 50s. But by and large, dementia, as most of you know, is a problem of older people. So one of the conditions or associations of why dementia might be more prone to getting COVID-19 is because they're just older. The other thing is that a lot of people with dementia might be living around in congregate living. And it's a shocking thing, and it's a sickening actually to hear about it, as you hear every day. I could talk all day about this, like my mother living in a nursing homes, group homes, developmental centers, VA centers, ships of the Navy, meat packing plants. What do we all see about the commonality of people living close together or working close together? Believe me, folks, there's nothing coincidental about it. It's all proximity. So big cities like New York City, it's obvious why people in New York City, hate to say, my daughter lives in Brooklyn, it's scary why this is affecting. People with dementia also have advanced diseases that also affect their breathing and swallowing. So dementia, by and large, is really problematic because of the association of some of these factors. That's really as much as I can really say about dementia. But people with intellectual developmental disability and Down syndrome, what about them? Well, certainly in the general population of IDD, based on their level or type of the developmental disability they have, if they have associated IDD that's associated with problems already with breathing or swallowing or lung issues, that's bad. Sleep apnea, commonly seen in Down syndrome, bad. If they have underlying heart problems, bad. Weakened immune system, bad. So in people in developmental disabilities, IDD, or Down syndrome in particular, that have had chronic diseases, there's absolutely no doubt that they are at risk of not only getting the virus, but getting it bad. And then also, again, congregate living. So a similarity between people with dementia is the same kind of thing. And the other issue with COVID-19 and IDD is what is the issue about, and this would also be true for people with Down syndrome, is those that also may be associated with problems of following commands, to be able to wear a mask or follow the hygiene and social distancing. And then certainly I don't want to be lacking in talking about issues of the caregiver. And we could talk a lot about caregivers, and I know that many of you who are probably on the call work with agencies or in the practice of supporting people who are the direct support professionals like I do. But there really is an uncertain amount of data to be known for sure in some of these things. But there was research that just came out, and that's the top right. And that's a study that specifically looked at people who did not have IDD, and the orange shows that people that did have IDD. And this is a study that looked at in the last few years of people that had basically pneumonia and died from it. And there's no doubt that people who have IDD, including Down syndrome, have a much higher chance of getting pneumonia and dying from it. And this is not specifically COVID-19. This is before the COVID-19 came out. So we really know historically that the people in our population that we care about have historically already been shown to have these numbers of complications. The other associated difficulties that they might have, specifically in Down syndrome, which I don't have listed here, would be perhaps obesity might be relevant, or scoliosis or spine disease might be relevant. Those are the kind of things that also might be perhaps relevant in this population to have more of an impact upon not just getting COVID-19, but also having it very problematic. And as we all know, from a standpoint of is this really there in the United States in terms of IDD, I'm sure all of you are quite aware that the stories every day that we hear in the news or read in our newspapers is there. So there's just I'm trying to keep up with the updates on news articles. It hits our front door. There's an article that came out not too long ago in early April of a home of people with IDD where they're seeing a surge of COVID-19. And I wouldn't say it's shocking, but it's sad to hear about that. So no doubt, are we hearing about it and seeing about it? It's a reality that people with IDD are much affected by COVID-19. It's just a fact and reality that we're basically seeing that. What I want to focus on now in the rest of my talk is really talking about the timeline of COVID-19 as it goes through historically through the situations that we see. Number one is that what happens before, even in the beginning when we first heard about COVID-19 in all of us, what do? We learn that we should keep distance. We learn that we should keep away. So I'm going to be focusing on some topical areas in the next number of slides that focus on social distancing and how people react under quarantine. And then I'm going to talk a bit about what happens when people get sick and what happens when we go to the hospital and what happens when there's a recovery from the infection. And then when I say we, this is people with IDD, dementia, and I'm basically going to make some personal stories. And what I've done is I've actually done a lot of interviews in the last month or so, and I've actually talked to a number of families and organizations who are able to provide me very personal stories about their own journey through these different areas somewhat in this respect. And I really want to put some faces to these situations that really talk about it. Social distancing and isolation. So here is these are people that I know. At the top right is Scott, and the other picture is Kathy. And right now these are recent pictures given to me by their family members. Thank you very much. Who are really showing them at home right now in social isolation, distancing from others, and they basically both of them have Down syndrome and early onset Alzheimer's. And so basically what happened to them, or what is happening to them, is what happens if any change of routine. What happens to them, and I'm being somewhat rhetorical, if they're placed in a restricted environment. And I say it in somewhat of a rhetorical way. I'll say, well, what do you think happens? It's very hard. So basically, if they don't really understand about why can't I go out, or why can't I go to my program, or why can't I come close to you and hug you, or why can't your family member direct support hug you? How do you explain to them? What is their now ability to go through this? And they're trying to now we're all living in trying to make this as normal as possible, because this is a situation that we're all trying to be normalized in their life to make this into a new normal when it's still a moving target. So the stress, I'm sure all of you know it. You're all stressed. I'm stressed. You know, I'm having my little red wine right now, and I'm drinking to you guys. I'm maintaining my semblance of senility, or my ability to talk straight here. But it's scary. I mean, this is a scary situation. So how is it for people supporting our loved ones and those that we support? It's a scary situation. So trying to maintain it, especially in someone who is having underlying, Down syndrome or cognitive dysfunction and dementia, it's really a real challenge. So I'm here to talk about it, because these are situations that what do the people do about it? So right now we talk about it, but what do people do to really find solace to be able to settle this down? And there's a lot of time that hopefully we maybe have time to talk about it, is what do we do? What do organizations do? What do families do? What does the direct support people do? What does the family do to basically deal with these issues? And this is basically without the virus in the home. But the one thing that's very important to remember is that if they have already an underlying health condition, their diabetes, their obesity, their sleep issues, their behavioral issues, that doesn't go away. None of that ever goes away during the time of COVID-19 under restrictions. So those issues really can't be ignored. And so it's a big issue when it really comes to crisis management on the healthcare side, because right now, all of us, and I'm a physician, we're trying to deal with it. We put out the fires. So what happens during this time? It's again a rhetorical question. What happens in our ability to make sure that we're not forgetting about these issues, maintain their blood pressure under control, maintain their behavioral issues that we had on medication, maintain their sugar, maintain their thyroid, all that. And also ensure, obviously, that the caregivers themselves, whether it's a family member or direct support professional, oh my gosh, you gotta make sure how do you think they're feeling about it? And then for me as a physician, the ability, and there's those pictures showing you telehealth, that's what I do now in my office, providing telehealth services to continue to maintain some level of normalcy of healthcare. And certainly in maintaining care, and this is both from a social standpoint and psychological standpoint, is the technology of staying connected. So I know for myself, I had a Zoom call with my son and daughter. My son's in LA, my daughter's in New York. My wife and I had a nice Zoom call. So you might hear, maybe you are doing it, hopefully you are, is now I'm hearing more from my friends and we're talking, we're trying to make the best of a terrible, scary situation, staying connected and maintaining semblance of normalcy in the crazy world as long as it lasts is huge. But it doesn't end there, folks. The issue about getting, staying isolated then sadly enough turns into the situation of getting sick. As we know, obviously, all these thousands of people got sick and are dying, but then we have to check for the symptoms of illness. And how does that happen? Fever checks, GI symptoms, breathing issues, and ultimately the COVID-19 testing is done. And I'm going to talk about this in a little bit. And then it's the issue, what are the care practice? What is the, just say you're working for an organization and you're trained on how to quarantine and self-isolate, but what are the practices that any organization is there to make sure that if this happens, what do you do? What's your go by? What's your instruction? What's your issue that you would do? So the organizations I do work with a lot of associate organizations have care practices in their program that are clear. They really need to have black and white programs. And certainly what would be great to have is a uniformity between organizations, because it's basically, there's a lot of similarity between many community support organizations on how they care for people. And what does that mean, obviously, for the organization and the direct support professional on them. One of my brother-in-law is actually worked for the ARC in Maryland, and so I hear about him all the time. He's under a quarantine situation with the people he supports in his group home through the ARC, and about what happens to him and the equipment he uses under quarantine situation. What is the personal protection equipment or PPE that he uses, his organization uses to protect themselves? And what happens if the illness it gets worse? As we all know, and I'm sure you all are hearing about this, when do people really need to go to the hospital? And we know that the hospitals, emergency rooms, urgent cares are basically saying to people, don't come. We don't only come if you're basically getting really bad. And then, of course, there's a whole issue of stress management and dealing with the issues of anxiety and depression during all this time. I can talk all day just on this topic alone. But the wonderful thing is that we do offer resources. So there are resources that do have information to the far left that says COVID-19, buy-in for people with disabilities. It's a written document that talked about it. Like we are tonight, we're having this webinar that we're doing. There's our good buddy, Rick Rader, who did one for the National Alliance of Direct Support Professionals. I'm doing another one for ADD and NDSS, and I'm sure you're hearing about others. And also to the far right, the number of organizations associated, affiliated with Down syndrome organizations have put together a question and answer to break down a lot of questions that families or organizations may have. And right now, if you've not seen that, right now, currently it's being updated because things have changed. So that information to your right, there's a link that really goes, that's from the NTG website, that really has it in both English and Spanish about some of these questions and answers related to COVID-19 and Down syndrome in particular. Well, sadly enough, the virus proceeds in a lot of people where they have to go to the hospital. I'm going to talk about the issues within the hospital system. So today, lucky me, I was in the hospital. I wore a gown, I wore a mask, I wore my N95. So I was very close to home with that. So I'm going to talk about testing, treatment, make sure we're getting the necessary care, the level of quarantine, the issue about communication, but also I just want to just briefly talk about palliative care and death and dying. Palliative care is the offering that's provided to people that are really sick and ill and chronic diseases. And this is what happens to people that get COVID-19, and you're hoping they're going to get okay and get better, and they're going to need that kind of type of physical or rehabilitative services once they're discharged from the hospital. So palliative services are often thought of in the hospital system, but tragically, people, as you know, die. And I had a whole bunch of images, and I just basically took them away, to be honest with you, that really focused on death and dying in the hospital. I thought it was basically, I'm not looking to hide it. I'm not looking to not talk about it, but it's terrible, because basically what is happening for people, they're dying alone, they pass away alone in the hospital. They may not be having a family member, because as we know, the people who are allowed to come into the hospital system, I'm going to talk about in a minute here, are basically your families are not allowed, direct support professionals by and large have not been allowed, and it's a tragedy. So even the ability to be there during this phase, it's sad. I mean, it's such a sad thing that people are even dying and even having a funeral service, and it becomes like a number. I mean, it's numb. I don't know how you all feel about it, but I watch a lot of the news too much for my own health, which is kind of why I'm drinking wine. It's terrible. Every day you're seeing all these numbers. It's a number of dying. These are people. I mean, it's so tragic. It's such a tragedy what's happening. But there are things that can be done in the hospital system, like, for instance, communication. So for those that have IDD, dementia, or other forms of IDD, there are these what are called like My Passports or information. You may not be able to see it from where you're looking on my PowerPoint talk, but there are these written documents that are information that can be given and brought into the hospital that do talk about someone with IDD in terms of their underlying health issues, their social issues, their personality. So that would be basically, I guess, an absence of having someone personally be there for them. And there's links to that, and we can share that as well. The support professionals who are basically there to support them. One thing that came out just recently through what's called the CARES Act, C-A-R-E-S Act, is a provision through our government that enables the direct support professional to actually get paid for them to be able to go to the hospital. Previously, and I maybe you or may not know this, is that previously for an organization to allow or have one of their DSPs go to the hospital, is they may not have been able to fund them or pay for them throughout their budget. They may not. So now through the CARES Act, there's this part that says you can pay someone to be there for them. So there is that is happening. And now I just want to also talk about this now, because this is a really big thing, is we're now working, the AADMD, the NTG is working on, it's called the hospital visitation rights. In New York State, through the Department of Health, just about a few weeks ago, they had passed a policy that allows people with IDD. They passed a policy for people with dementia that is enabling people who go in the hospital during this time of COVID-19 to allow a family member or direct support professional to go in and be with them. And this is a policy that was passed. It's now being worked at in New Jersey, Tennessee. And we in our organization, I'm helping to spearhead it, are now just today, we put out on the ADMD website information about this amazing, I'm calling it amazing, I'm pretty biased, this amazing national campaign that you and everyone on this call, please ask us after this call about a link. We're also putting a petition, and we want this to become a national effort around the country for us as advocates, overall advocates, to basically spell out and say, this is something we can do. Hospital system can have the ability to have a family member support professional to go into the hospital, and below the information on the forms for COVID-19, it says Disability Rights New Jersey. That was just put out in my state of New Jersey. It's now talking about what we do or can do or try to do in partnership with advocacy organizations, the DD Council, the ARC of New Jersey, working together with the Department of Health in New Jersey, the governor's office, to fight the fight and do the right thing. But it's going to take a fair amount of stringent advocacy and all of us to work together. But it's a fearful thing, as we all hear about maybe people that get sick. Yes, go ahead.
I'm sorry, I thought it was a great time. We do have a couple of listeners on. I'm close to the process of our second series, and we have Michelle Kerrigan and Dr. Jean Kerwin on. One will be talking about exactly this issue in detail and some of her experiences, and the other talking about palliative care and how it can be a resource and something that can help all of us during this time, especially those of us caregivers and care about people with IDD and dementia. Additionally, in the second series, we have Rick Rader and one of his staff. They will be doing 2 series addressing how you talk about COVID ID with people with IDD, and also how you can help make the residents an easier place to live. And then next week, I will be talking about the whole issue of social distancing and ways to do that with sensory information and with the physical environment. So your talk is perfect, and I just want you to know that we do have people on and that there will be complimentary to this. So thank you.
Oh, that's great. Kathy, thank you for chiming in, because that is so true. Because really, I don't know if I'm talking like a mile a minute. I apologize, because I really want to go over a lot. But the beauty of what Kathy just said is so true. We're basically going to have, as she said, these different conversations that are going to go into more details about these other issues. And the other thing that we're also doing is we partnered with the National Down Syndrome Society to also have presentations also related to mental health concerns as well. So there are a number of things we're basically all doing, as you know, the best we can, each of us. So I'm glad that we have other healthcare and social perspective and issues related to that. And this slide really just talks about the issues about sounding the alarm. And certainly there's certainly always been a concern anyway in people with IDD about equity of care. Are we really basically always having due diligence to care for people with IDD? And I'm singing to the choir. I know that for everyone who's on the call, historically about people with IDD being devalued and marginalized population, and we're certainly better than we used to be. But certainly under times of crisis, systems fail. The people aren't always there. And I really wanted to show, here's this, if you can see it, it says, this is a picture of Matthew. And Matthew with his mother, Susan, live in Alabama. And so it says, I am ventilator worthy. I want the right to live. Can you imagine that? I mean, it's amazing. That came out in their paper in Alabama, April 18th. And this came across my email a little after that. And I immediately said, oh my God, that says so much. And what do they think? And so I immediately, through the reporter who wrote that article, I was able to fortunately get on a call to Susan, who basically is a wonderful advocate for her son Matthew. And she told me the story about her as an advocate and her life and what she did and the fear she had. So basically, just like all of us, you're fighting the fight, and you want to make sure that you're basically put everyone in the right position to make sure that there isn't an issue. So certainly advocacy is hugely important during this time. And our colleagues at the University Centers of Excellence, that's a middle document through AUCD, are working for the Center for Dignity in Healthcare for people with disabilities. And recently they had put out this document, Safeguard Against Disability Discrimination During COVID-19. And then finally, again, I don't want to steal the thunder from my colleagues talking next time, is through the Office for Civil Rights. There's no doubt that our government is there, hopefully protect us in different ways, and they've actually gone to Alabama, they've gone to Washington State, they've gone to Pennsylvania when they see signs of abuse or neglect or potential thereof, to basically go after that and make sure that there's equity of care and people are not being discriminated against when it comes to access to, say, ventilators or to medication. So I think I like to believe that I feel good about it, but it's also trust but verify, right? We're never going to fully trust our system along the way. So I would just put it that way, but you'll hear more about it. So when people go, I'm going to go back to the hospital for a minute here. So when people go to the hospital, you hear a lot about the different tests that are done. And there's different kind of tests that are done. You can do the nasal swab. There's material that can be done from the mouth and the blood, fecal material, and all that is really looking at for evidence of the virus within in the body. And what's to the far right is a graph that shows how the virus may manifest in the blood, in the fecal material, in the mouth, and it's basically looking for particles of the virus, either by what's called RNA or what's called antigen. And the antigen is actually looking at like the surface of the virus. Remember back in the early slide, I showed you there's like dots around the circular virus, the dots. You can call that like an antigen. That's like material. So the testing that's out there looking for whether you have COVID-19 or not are looking for these different things. The other thing that test is also looking at is our immune reaction or response to the virus, and that's called IgM and IgG. So this graph to the right shows a timeline when different things may show up in the body. The RNA is earlier, the antigens earlier, but as someone gets into their system, the body then begins to build up the immunity. The IgM is an antibody. Ig means antibody, Ig is antibody. IgM is the first type of antibody that all of our body generates when we ever get sick, and that's the first thing that shows up in the blood. IgG is a kind of antibody that starts later and lasts for years and years and years, and that's basically what vaccinations are. Vaccinations are the ability to give something into our body to build up IgG, this antibody against. So in other words, if you got a vaccination against measles, mumps, rubella, polio, or the flu virus, you basically will get this immunity. So if you ever have it near you, the antibodies in your blood are already there to knock it down or keep it away. So that's kind of this real quick and dirty, the testing that's done. And then the question is, how long does it take to get some of these back? The other part of the test is how accurate are they about getting this reality of information? Are they thoroughly, reliably showing these things? The one thing that's tricky with coronavirus is because coronavirus also could be a common cold virus. Sometimes it's concerned that some of the so-called positive coronavirus in some people may not be COVID-19, but it could be another variety of a COVID virus that's in there. So that's called a false positive. A false positive means it's showing a result of something that's really that shows it's there, but it's really not. A false negative, you may have heard these words. False negative means the test result comes back negative, but the person really has it. False negative, and that's sometimes going to happen. And so there's a concern that some tests may not be always effective. Then when someone gets in the hospital, like I showed you on the slide earlier, the symptoms, the signs of what might be COVID-19, and the other tests are done, x-rays of the chest, CAT scan of the chest, and this is all that my mother went through of various testing, all those things my mom went through, and then also these various blood tests looking for the effects of COVID-19 to the blood, and there's different elements. And also it says include other pathogens. Bladder infection can cause similar problems. Flu virus can cause different problems like that. So when people go into the hospital, they're being tested for other things as well. So treatment, well, the point of treatment is to keep it from spreading. So if someone goes to the hospital, that's where the whole equipment comes into play. That's why people are all dressed up in all these different areas, but you don't want to get other people sick. So when someone goes into the hospital with COVID-19, the key is to keep it from spreading to other people. People with COVID-19 get a high fever, so Tylenol is often given. People are also often given fluids, and if they can't eat well, they're given nutrition. And the biggest complication of COVID-19 is respiratory and heart problems. And sadly enough, one of the common things that people die from with COVID-19 is sudden death. The heart just stops and people go into cardiac arrest and they die. And what we hear about, and it's not a happy story, what we hear about with COVID-19 is that we hear, oh, don't go to the hospital. It's not good, wait till you're sick. Well, guess what we hear that happens? People wait till they're sick, and as soon as they get there, they die in the emergency room because they waited so long. So it's a catch-22. It's a really terrible situation of when people should go or not, and what the messaging is of what we in the healthcare world are telling people to do. But respiratory problems clearly and heart problems is really what ends up killing people and what they're dying from. The therapy of the virus itself is what's called antiviral therapy. And antiviral therapy is basically to kill the virus, which would be analogous to if you had a bacteria in your body and you're giving an antibiotic, penicillin, erythromycin, doxycycline, they're antibiotics. Antiviral medications are different. They're different kind of drugs that kill the viruses. And it says here, stopping the virus along its life cycle. And the complicated thing, again, I don't want to get in the weeds of viruses. Viruses get in the body, they attack the cells, they grow, they replicate. So the different medications that are being looked at to affect the virus are there to affect the virus maybe at different points of its lifespan, getting in the body and throughout the body, getting in the lungs. So there are parts of that. Hydroxychloroquine, which is called Plaquenil, as you may hear about, my mother's on it. My God, that's why it's so close to home. My mother's on hydroxychloroquine, which is basically a medication that's been used for rheumatologic disease. My mom's on that, and showing some maybe favorable evidence in certain reports, but we're not really sure. The two below, remdesivir and favipiravir, are medications that are used now in research that are showing possible benefit to often killing the virus in research studies. These are IV medications that are now in research studies in the United States, and I believe outside the United States, that are trying to show how they can kill the virus. But this is all research. That's why I have question mark, question mark. We don't know. This is all a moving target, and the research is in research study to know if it really is valuable. And the other part is called convalescent plasma. As you may remember on the slide before, I was showing these antibodies, IgG. So if you had, or if a person got the COVID-19 body and their body build up immunity, and you have these saving IgG, which are antibodies, if you then give those IgG antibodies to someone that has active COVID-19, maybe those antibodies can now fight off in someone else. So what they do is called convalescent plasma. What plasma is when you go and like donate blood. If you've done that, they take the blood and they spin it down and get off the fluid, and they take the red cells out, and it looks like a light yellowish liquid. That's called plasma. And in the plasma are proteins, which are also antibodies, and that's what's called convalescent plasma. So there's studies to show that in people that have already had COVID-19, does their plasma that you can use to go to another person help. Treatment also is mental health. So mental health is huge. Obviously, the stress in everywhere, shape, and form is terrible in every place. So dealing with it, can you imagine, again, going in the hospital? You're in the hospital and you have these people who come up to you wearing gowns and gloves and masks, and you can't really hear them well. They look like scary monsters or robots. I mean, can you imagine? I mean, I see it. I'm one of them sometimes. So it's not pleasant, and it's very stressful. And of course, stress to the care providers. As you hear in the news, you're hearing the healthcare people that are crying, that are at the end of their shifts, and they're basically seeing death and dying day to day. It's insane. I mean, I think we're just going to see a whole group of people that are going through this pandemic that are going to be, have a post-traumatic stress syndrome or something affecting them, dreams and difficulties. This is really a terrible thing that we're going to have to be dealing with as a society for a long time. The issue of communication during the hospitalization, and this again goes to the issue that I talked before about hospitalization and the importance about trying to communicate. So with my mother, because we're not allowed to go in her care facility, is we did a Zoom call. Or in the hospital system, a Zoom call or telephoning. But it's really, it's only as good as it's good. However, that's why we're so much important towards having that ability through our visitation system or policy to say, come on, we can do better. We can try to change it. That's kind of why we're really doing it, because communication is huge during that time. And we do also at the same point, we respect the doctors, we respect the hospital, we respect the nurses, because they're basically saying they're saving lives. We know that. However, we can't leave the emotion and connectivity at the door. To say that we feel okay just to drop the individual off of the emergency room and basically go into this big black box of the hospital, and you're like, what's going on? What's happening? They're in there. We don't know. It's insane. That's normal. I mean, that's basically what it is. I mean, that's our normalcy, folks, as you know. I mean, that's what's happening around the country, around the world. People are going to hospital systems, and the hospitals are struggling. I know they are. I mean, I work in a hospital, and they're struggling trying to maintain. They're trying to get it together, but we really have to find commonality between supporting the hospital systems and caring. But also, as the treatment goes on, God willing, people are going to survive. So it's a matter of planning post-hospital discharge. So there's no doubt that's important. We also really do appreciate that there's need for prevention, as we're all doing now, social distancing, hygiene, and the whole issue of adequate personal protection equipment. Oh my God, it's unreal. Do we really know that what we're wearing or have with us, even day to day in your home, what you have in your so-called surgical mask or bandana, is that adequate? You can call that personal protection equipment. It is. There's that goofy picture of that woman, and I guess it's tongue in cheek, I'm assuming. She wore like little plastic cups over her eyes and a bandana. I mean, I put it up there to be funny. I mean, I don't know if she's being funny or not. And then people below, and they're in all their gown, and they're trying to be, they're trying to live their lives and show heart. And there's different levels of equipment. So even in my hospital, I wore the special masks, which are there below, called the N95, and there's a surgical mask, and there's a plastic shield. But really what it is those kinds of equipment are there for the hospital system. But what about people in group homes? What about people in nursing homes? Are they really, and this is kind of a rhetorical comment, are they really being afforded the quality type of equipment to protect themselves and the clients and the individuals there in group homes? I don't think so. I don't really think so. I mean, I'll just come out and say, I don't think so. And that's why it's so problematic that we're having the news day after day after day of all the people that are getting sick and spread. Why? Why? It's because they really don't have the ability to have the social distancing because of congregate living, and also they're not really given the appropriate equipment. They're not. I mean, the hospital, I mean, I get that, but I think what we're going to lesson learn in this whole system is a whole change of what we're really learning from this, that we really need to focus more on family life, group home care, protection. I guess you could say, who knew that this pandemic would be like it is now, or putting the importance of direct support professionals in the back burner. Well, guess what? It's now happening, and it's time, and that's why we're paying the piper, because basically we in a society weren't paying enough attention to it. Vaccinations, unfortunately, the research on vaccinations, we may not have a vaccination for about a year. So the coronavirus, COVID-19, is going to be around for who knows, until we have enough people that are immune to it for the next year or so. So the whole issue about lightening up, and again, I don't want to get into whole politics or philosophy about it, it's not a small issue about what we do from now till then when vaccinations come around. If the virus itself, it may not be like the flu virus, which basically went away during certain season that came back later. This virus may be around, may not be going anywhere. So as soon as the ability to open back up our society, the virus might be just waiting. It just might be waiting. And I hate to be, fearful about it, but I am, to be honest with you. Well, people do get better. And I use the term post-COVID-19 stress, and I can call it post-COVID-19 stress reaction. You can say current, because there's a COVID accuracy now of stress reaction, but I think this is not going to be a simple fix when we recover. And I think recovery is the right way to look at it. Are we really going to get back to normal? Are we going to snap back to normal society? Are we going to go back to handshaking? Are we going to go back to restaurants and other places? Transitioning from the hospital in that respect, that's a difficult thing. Are group homes and family situations able to care for someone who's basically being discharged in the hospital? Because basically they're going to be, if they're discharged, they're going to be in a very weakened state needing care. Where do they go? Is the group home ready for them? Do they have the equipment to care for them? And the issue about going back to normal is not a small issue. And then also preparing for the next wave. So that little graph that I have there is really talking about the possibility of a resurgence of the COVID-19 virus when things calm down, when we've all now go back into our normal world, seeing people, being around people. The virus is there waiting to get us sick again, and that might be the fall. So this is really serious, and I really wish I had an answer, to really realities. And I don't mean for anyone to lose sleep over what I'm saying, but basically, as much as I like to find some information where I can say, oh, we're fine, I think there's a lot of uncertainties that we don't know. But I definitely feel that there's got to be a lesson learned and take note on what we're seeing and learn from this experience, because we're all going to get through it one way, shape, or form. But we have to really make sure we remember this and learn from this. So therefore, God forbid, another pandemic comes around, our society, our culture, our group homes, our organizations are really prepared. This is my last slide. This is very interesting. I found this on my Instagram account. I found this on my Facebook. This is from Whiteboard whiteboard psych, and this is a woman who basically is a psychologist, and she does this whiteboard where she does these really interesting drawings, and she really puts up these emotions that go through us, all of us. I'm sure you can look in the shock, the betrayal, the envy, the frustration, etc., that we all have gone through from day one. I know I have gone through some of these, and it's a motion thing for us. What do you feel? I can't believe it. I'm shocked. It's fear. And we go through all these things. Ultimately, we want to build up at the end solidarity. We're working together like we are now. So the beauty, and I hate to say, I guess I'll say this, I hate to say it's a silver lining. So with the benefit I see in what we're doing, and this is my silver lining, we're all getting together. We're all working together as organizations, arms in arms, hand in hand, working together, and I'm seeing this more and more. We're fighting strong. We want to believe there's a better day, and we're going to learn from this. And I definitely see that, like this whole thing with the hospitalization policy. Oh my God, when I started talking about this not only like 10 days ago, and I started talking about some of the national leaders in IDD and disability, oh my God, and they said, yes, let's sign on. What can I do? What can I do? So right now, we're right now positioned to fight the fight and join up and work together for a better day. So hopefully I covered a lot. It was pretty quick, and I apologize I went too fast. So Kathy and Catherine, I'm going to hand it back to you.
You don't have to apologize at all. When I interrupted earlier, it was just to say you're doing exactly what we needed you to do, and I'm getting many comments from people saying I love to listen to Seth. He covered a lot of material. I do also want to, I did fail to mention that Kathy Service, I believe I saw her name, is also on tonight, in the whole discussion of ventilators and ways to stay healthy in our group homes and with people with IDD throughout this crisis. She will be discussing on May 2nd, I believe it is. Nope, sorry, May 5th. I'm also getting more messages through. Well done, and thank you very much. Wonderful, such important information. This is, by the way, being recorded, and it will be available, as Catherine mentioned at the beginning, on Thursday. All 4 of the sessions are being recorded and will be available. Jean Squires just got thank you, Seth, Kathy, and Kathy. Angie, very informative. Thank you. Thank you, Seth from Adel. Great presentation. And Catherine, yes, it is being recorded. Great job, Seth. Thank you from Laura Robinson. Julie Snyder, thank you, Seth. Well done.
Thank you, guys.
Your mother. Thank you. And yes, sorry to hear that about your mother.
Yeah.
Seth.
Thank you, everybody.
Really sad for you, but hopefully she'll pull through. So we're all on that. Melissa Kushner, thanks so much. I hope your mother recovers as well. I have a question, and there may be a few others as well. I don't see any more, but one is about the access for people with IDD to testing. I know it's already it's challenging for anyone to get the testing. Is there any indication of any resistance to providing testing material based on someone's IDD, or is it just the same challenge as all of us have to getting the testing?
We're all challenged. Basically, I think the big thing right now is those that are getting tested that are those only, for the most part, that begin to have some signs or symptoms of the virus. They're not testing asymptomatic people, and I didn't get into the whole asymptomatic number or percentage of people. And that's a real challenge. So if you're only testing symptomatic people or those that are carrying the virus, and they don't know about it, it's really difficult. But it's an issue, and it has to go with enough testing equipment or the materials that go into being able to put the testing materials together. But right now, I have no evidence suggests at all that anybody with Down syndrome or IDD is in a different level of being tested. I don't think, I'm not seeing that at all.
There's a thank you for the info. How do we get the recordings? Catherine, do you want to mention that again?
Yes, it will be sent to you in a follow-up email on Thursday.
Great, thank you. And Kara, thank you for talking about mental health concerns. As a therapist, I agree there's going to be fallout from this that we need to be prepared for. Yes, and one of the later sessions in June, in the second series that I'm in the process of putting together, and hope by next week we'll have all the information out to you. Mental health is the major focus. Mental health for caregivers, taking care of ourselves as well as taking care of everyone around us as a result of this crisis. Angie, there are tests being done without symptoms that are for people that are having surgery. Okay, great, thank you. Kathy, service, some issues may be with the testing itself, toleration. Good point. And I'm assuming, Kathy, that you'll address that when you do your talk on May 5th. Catherine, Michelle, the recording is sent to everyone who's registered 48 hours later. Kathy added to that about the toleration with the nasal swab. I could see just looking at the swab has made me wonder if I could tolerate it. Malia, thank you for this informative training. Hope your mother fully recovers. And Sandra, thank you. Great presentation. Marianne Tolliver. Hi, Marianne. Wonderful you're on. We've had one person with some symptoms who was tested and his test was negative. He tolerated the test better than I might do. Great point. We're also individual with that. I don't know if I see any more awesome mahalo from our friends in Hawaii, Seth.
Mahalo, great.
Wonderful. Let's see, I think I'm down to
I think that's all. Yep.
Yeah, I think that's all.
No more questions? Oh my gosh.
But
well,
don't forget, we have another webinar coming up.
That's true, right. It was not meant to answer every single question, but that's true.
Yeah.
Don't forget, you'll all get reminders because you're all registered. But next week on the 28th,
more good
we have our more good material from our own Kathy Bishop, who's going to talk about social distancing, dementia, COVID-19, and IDD. And she's going to give practical tips and talk about the challenges about social distancing for our particular population. So you'll all get reminders of that from email, but don't forget that's coming up.
And there is the one more Kathy service the week after that, May 5th, that you also will get reminders. We also at this point have planned that the next series will start May 12th with Rick Rader doing the very first one in the second series. At this point, we have 5 that will be in that series, and the information will be going out as soon as everything gets fine-tuned. What is the time of the next week's webinar? All of them are scheduled 6 to 7:30 Eastern Daylight Time. If any of you have questions of what we're not covering, you have suggestions, you hear someone that has really added something to the whole dementia and IDD component with the challenges with COVID-ID, please do send them to myself, Kathy Bishop, or Catherine Piers. Seth has put down the website. Is this the new website?
Yes, that's the NTG's updated website. Yep.
That's it. If you haven't checked it out, be sure and do so, everybody.
Yes,
yeah,
please.
Absolutely.
So that's it. Seth, thank you so much.
My
Above
pleasure.
and beyond, it just was wonderful.
Thank you.
I'm sorry you're personally challenged with this, but we will send.
Yeah, very sorry to hear about your mom.
Yeah, thanks, guys. I mean, I threw that at you. I don't even know if you knew. I was thinking ahead of time what I would tell you, but anyway, surprise.
You know, Seth, since
well, you
we
have a lot of
minutes before, you could have told me then.
I'm sorry. I guess.
Well, and you have a lot of support here, so keep us posted.
You guys are sweet. Thank you, guys.
We'll be thinking of her.
I know. Thank you very much.
Thank you, everyone, for coming on tonight. We really value you taking the time, and we look forward to you being on next week.
Absolutely.
Any questions, please send an email to Catherine Piers or myself. We'll be happy to try to answer them. Have a good week and stay safe and healthy during this difficult time for all of us, but also look for moments of at least a smile or some joy as much as possible and share that with others. Thank you.
Thank you, everybody.
Thanks,
you.
everybody.
Good
night.
Good night.